Good morning, everyone, and thank you for being with us in this community chat of today about colon cancer screening. We're going to learn if it is really necessary, and if so, why, or maybe not. We'll see. But in order to talk to us about this, I feel so blessed today because we actually have two wonderful people, specialists, like very highly specialized. So I feel very privileged to have them with us today. So Dr. Cromfold is a board certified and fellowship trained surgeon practicing at Highland Medical and Highland Surgical Associates in West Nyack. And Dr. Eric Teeter is an MD, is a gastroenterology specialist here in West Nyack with over 23 years of experience. So I'm gonna let them talk to us a little bit, and maybe they wanna introduce themselves as well, tell us a little bit about them and how they got into gastroenterology, and that way we get to know you personally a little bit more. So who wants to start, Dr. Tater?
Sure. All right, so I'm Dr. Tater. I'm in Rockland County here since, for about 17 years now, and I've been practicing medicine for 23 years. Colon cancer screening is one of the main things that we do in our office, amongst other things having to deal with reflux, pancreas, liver disease, and other things. And of course, March is Colon Cancer Awareness Month, so it's rather pertinent that we're talking about colon cancer at this point in time. And so for today's talk, we're going to go through a number of things here. One of them is we're going to talk about what colon cancer is and what are polyps. We're going to talk about who gets polyps. We're also going to talk about how you screen and look for polyps and how you remove them. And we're going to especially focus in on the colonoscopy procedure. And then Dr. Cromfold is going to talk about surgical options should, unfortunately, anyone ever be diagnosed with colon cancer and some of the treatment methods, okay? So getting into colon cancer itself, obviously the first question then is, what is colon cancer? And just like any other cancer, it's out of control growth of cells. And the symptoms that you can get include some of the following, okay? As the tumor in the colon gets bigger, it can cause a blockage or an obstruction of the colon. So it could present in that way, either having a change in your bowel habits, or maybe having an obstruction where your belly gets distended, you have nausea, you have vomiting. So that would be one way that colon cancer could present. But it can also do other things. It can bleed, so you could see blood in your stool. With colon cancer, you could become anemic if it's bleeding slowly over a long period of time. And that would result in somebody feeling weak, maybe having some shortness of breath, and feeling very out of sorts. Other things that colon cancer can do that may present as, it could theoretically perforate or cause a hole in the wall of the colon. And this would result in maybe fevers, a lot of abdominal pain. It would be presenting like an infection. There is another common type of infection called diverticulitis that can occur when little pouches or diverticuli in the wall of the colon get infected, and this could look very similar to a colon cancer perforating or causing a hole in the wall of the colon. So sometimes these things could present in a very similar way, and therefore when people have diverticulitis, we have to be very careful afterwards and make sure that it's not a colon cancer that's there that's mimicking diverticulitis. So we often take a look in the colon after a bout of diverticulitis just to make sure it is indeed diverticulitis and not colon cancer. Also, colon cancer can spread to other areas in the body and cause problems. The primary location that colon cancer moves to is the liver. This is because the blood flow in the colon goes right to the liver first, where things are detoxified by the liver. So all those things that you eat and ingest go filter through the liver first, where they get processed. And also the tumor, if it breaks off or spreads, it also goes through the blood supply to the liver as well. So you can get liver issues from metastatic colon cancer to the liver. This is what a normal colon looks like here on the left. A nice clean colon, by the way. And on the right side here, you can see a tumor that's growing there. You can see that it's bleeding. You can see that it's causing a near obstruction or blockage of the colon. So obviously this is what we're talking about and what it looks like. Now, in the olden days, and perhaps still some today, they would do barium enemas to look at the colon, and this is just illustrating what's called an apple core lesion right here. You can see right here a real apple core on the left side, and then this right here is the apple core lesion in the colon. This is what you oftentimes find if you have a little bit of a more advanced colon cancer that's maybe causing a blockage there. This can be seen on a regular CAT scan as well, but this barium enema just illustrates it very clearly. And then right here on the right side, we show a liver, which is this big organ right here that I'm circling with the arrow. And you can see little black arrows pointing at metastatic disease, which are basically cancer tumor growth inside the liver. And you can see that it's taking up a lot of the liver here. What would eventually happen is, unfortunately, that the regular normal liver tissue is being replaced by the tumor, and therefore you're not able to do the normal things your liver does. It's not making the right proteins, it's not making the right blood clotting factors, so you end up with bleeding issues. You may turn jaundice if your liver is being replaced with tumor because it's not clearing bilirubin, which is what makes you jaundice. So there's a lot of different ways that this could present that would mimic liver disease, okay? Now, colon cancer itself generally comes from polyps, and I have an example of a polyp right here that I'm pointing out with the little arrow. Right above it here is just light reflecting. That little white thing is just light reflecting off the scope, but this is the polyp right here. And almost all colon cancers, or the regular colon cancers that we're referring to, come from polyps, which is actually a fortunate thing because this allows us to do the screening. But looking at polyps, they start off really small, like little bumps, and then they get bigger and bigger, and then eventually they get big enough where the tip of the polyp usually has some cancer, which is signified by the whitish area. And then at some point it gets so big that the cancer now grows down into the stalk and then invades into the lining of the colon and into the rest of the body. Now, this whole process could take many years, all right? This could take 5, 10, maybe even 15 or 20 years to occur. So there's a very nice window of opportunity to go looking for these polyps and to remove them. Now, how do polyps exactly occur? Well, basically, there's a mutation that occurs. There's a change, basically, in one single cell that's lining the colon. Now, these colon cells, they slough off and fall off over time regularly, and they're replaced by new cells underneath that push up. Just like your skin sloughs off, and then there's new cells that come in and replace it. So the cells in the colon are constantly turning over, as well as the rest of the intestinal tract too. But for whatever reason, inside the colon, one of these cells mutates and it fails to slough off or fall off. And this is where the polyp starts to form. And then it just gets bigger and bigger. Slowly it grows. But that's basically how it occurs. Okay. Now, most of these mutations or DNA changes are sporadic or random. Okay. They're not inherited. They're just due to bad luck. So whether or not you form a polyp, there may be some mild genetic predispositions, but generally this is a bad luck issue. Only about 10% or less of colon cancers have a known familial genetic link. So you could be a marathon runner, vegan, perfect in every way physically, but you're still going to be at risk of having a polyp form. Now, there are 3 of the main genetic inherited things that I'm not going to dwell on them, but I just wanted to give you the names of them so you're familiar with it at least. One of them is FAP, which is familial adenomatous polyposis. And this is a condition where you get hundreds and hundreds of polyps in the colon. Usually we recommend that a colorectal surgeon like Dr. Kronfol here removes the colon at an early age because there's a 100% definite chance you're going to get colon cancer from this. And this is not a very common condition, but it is out there. In fact, I've seen somebody with this in the past year, and I think I've seen 3 or 4 people with this during my career here in Rockland. So it is out there, but not very common. Okay. The next one listed is Lynch syndrome, and that's a lot more common. This is a condition where you only get a few polyps, 3 or 4 polyps, but you get them at a very early age, maybe in your 20s, late 20s, early 30s even, or maybe early 40s. So a much earlier age than regular colon cancer, and it's also associated with other cancers like breast cancer, pancreatic cancer, and ovarian cancer. So it is a cancer syndrome where there are other cancers that you have to be aware of with it. And then the last one that I'm just going to mention is BRCA, which is the breast cancer gene. And yes, that is associated with colon cancer, but there's two BRCAs, BRCA1 and BRCA2. And it turns out that only BRCA1 is associated with colon cancer, just so you're aware. All right. And these have different mechanisms, things like mismatch repair and other stuff like that. I'm not going to go into the mechanisms. All right, so let's talk about some of the numbers here with colon cancer. And it's unfortunately the second or maybe the third, but usually it's referred to as the second leading cause of cancer death in the United States after lung cancer. And the numbers are not so great. There's about 150,000 people a year diagnosed with colon cancer. Okay, 150,000 is a pretty good sized number. And there's about 50,000 deaths a year. In fact, this is even a little lower. The official number is actually like 53,000. I just rounded it down to 50,000, but because it's easier to remember. But you know, these are significant numbers. Now, just to put them into perspective, I don't know, what would you say, Dr. Kronfol, automobile accidents are like around 40 to 50,000 a year, somewhere around there. And I think opioid deaths have now exceeded 50,000 a year. They're like 60 to 70,000 a year. So that just puts it into perspective of other, you know, epidemiological issues that are going on in this country. But I think maybe another way to look at this is your lifetime risk. And I would say lifetime risk is a little bit under 6%. So you have a little under 6% chance of getting colon cancer during your life. Okay. That means 6 out of 100 people. And you may say, okay, hey, look, that doesn't sound so much like a big number. But if you went over to the Palisades Mall and you walked around for about 5-10 minutes, you're probably going to see 100 people within 5 minutes walking around the Palisades Mall. And then to realize that 6 out of those 100 people you saw are going to get colon cancer, now all of a sudden it's like, wait a minute, it is possible that I could get it. So the numbers are out there. Also, just so you know, the average age of diagnosis of colon cancer is age 67. Okay. And there are some different risks in different populations. So let's talk about this little graph here that I put in. Okay. So here we have on the left side the rate of colon cancer per 100,000 people. Okay. And then on the bottom we have age. So you can see, looking at this blue line, we'll look at the blue line first. You can see that when you're 20 or 24, the number of people with colon cancer is almost zero. I mean, it's very low. But as you get older, it starts to creep up a little bit. And then around age 50, it starts to shoot up much faster. Okay, so there's a much higher slope of this line, which means that around age 50, at least in this population, the Caucasian population, there's sort of an influx, and all of a sudden people start getting colon cancer a lot more. It turns out African Americans start at an earlier age. The curve is shifted to the left a little bit, so they're really, you know, higher risk starting around age 45, which is one of the reasons that they lowered their age recently from screening from age 50 to age 45, because they felt that this would be more inclusive of the whole population. If you look at the part of the graph over here on the right, it says Caucasian screen at age 50, you're still missing 5% of colon cancer. And African American screened at age 50, you're missing 10% of colon cancer because it occurred before age 50. You know, these people obviously, you know, were diagnosed with colon cancer, so they never got their screening by age 50, but I'm just saying you're going to miss 10% by waiting until age 50. So if you lower it down to age 45, now you're back down to 5% miss rate. And still, you know, people are going to fall through the cracks. I mean, that's still 5% of people with colon cancer were diagnosed before age 45. Okay. All right. Just so you know, in terms of the screening, if you have a family history of colon cancer, you may start earlier than 45. A family history is defined as either one first-degree relative, which would be either your parent or a sibling or your children. That would be a first-degree relative. So one first-degree relative or 2 second-degree relatives, like an uncle or a cousin or a grandparent. That would qualify as having a family risk of family history of colon cancer, and would necessitate starting, and I believe they're still doing it at age 40. I don't think they went to 35, but it was starting at age 40 in those cases. The only other caveat would be is if they had it at a very young age. If your relative had it at age, 45, then you would start 10 years before that age. So instead of 40, you do 35 if the family member had a colon cancer at a really young age, like 45. The frequency of colon cancer screening, we'll talk about that a little bit later. Okay, so let's talk a little more about risk factors. So there are some things out there with your lifestyle choices that could make a difference. Obviously, you don't have a choice if you're male or female, but males do have a higher risk slightly of colon cancer than females, but that's not to say that it doesn't occur in both genders. As we mentioned before, African Americans have a slightly higher risk of colon cancer, but these following things are things that you could theoretically control. So low fiber diet. So if you have a low fiber diet and you're not eating enough fiber in your diet, you could be at more risk of colon cancer. The reason for that is theorized to be that high fiber in your diet helps to slough off those cells, that the roughage helps to break off some of the cells lining the colon so none of them stick as easily. And that's thought to be part of the reason. Now, it may be that there are other reasons too with this. Maybe it affects the bacteria in your colon, maybe the bacteria in your gut if you're on a high fiber diet. Who knows? But I don't know that that's well understood. Processed foods, it's kind of there with the low fiber diet, but processed foods could have all kinds of hormones and chemicals in it that may make it more likely to have a mutation. Especially if you're taking a lot of foods with nitrates, charbroiled meats, and who knows what kind of growth hormones and stuff like that we're ingesting when we're eating chicken and stuff, because a lot of times they do put hormones into the foods that we eat, and we don't know the exact effects that those are going to have. Moving on down the list, smoking can increase your risk of colon cancer by 25%, and chronic heavy alcohol use at least by 16% increased risk in getting colon cancer. And then, of course, on the bottom, we've got diabetes. Seems to be a risk for everything, as well as obesity, red meat intake we talked about a little bit with charcoal boiled meats. And believe it or not, gallbladder removal will increase, but by only a little bit, will increase your risk of colon cancer. Not to say that you should ever avoid getting your gallbladder out. If it needs to be out, it needs to be out. But it has been something that's been studied. Interestingly enough, there is a condition of the bile ducts. It's called primary biliary cholangitis, which patients take bile thinning agent. It's called ursodiol. And there's a lot of literature out there about whether, if you're on that medication for that condition, which is fairly rare, by the way, but there's a lot of debate out there whether you should be screened more often, whether you have a higher risk of getting colon cancer on that medication because of the way that it affects bile. Okay. All right. Let's talk about things that lower your risk. So those are things that increase your risk. Well, lowering your risk, it's well known that aspirin will lower your risk of colon cancer. But the question is it really needed? I mean, it may only lower just a little bit. So there are a lot of risks to being on aspirin, okay? There are risks of getting stomach ulcers. There are risks of getting kidney stress on your kidneys from being on aspirin. So there's always going to be a benefit and a disadvantage. So I can't say that you should be on aspirin just for the chance of reducing colon cancer, but it is a known thing that will reduce colon cancer. In fact, patients that have a genetic risk for colon cancer, maybe it is a good idea for them to be on aspirin. And they do give high dose aspirin to patients with that polyposis thing where they get the hundreds of polyps. They often do give those patients aspirin as a treatment. Other things that could lower your risk include B vitamins. They have been studied. Supplemental fiber, we talked about fiber before. Supplemental calcium theoretically can lower your risk slightly, and vitamin D, believe it or not. And that's especially important here in New York because I have yet to see anyone with a normal vitamin D level. Every time I see somebody draw a vitamin D on a patient, it's always low around here. Fish oil is something that actually works a lot like aspirin. It lowers inflammation, just like aspirin lowers inflammation, and it blocks a chemical that's very similar to what aspirin blocks. So they're actually kind of related in many ways. And so if you don't want to take aspirin, fish oil might be a better solution for you. And it has been shown to lower inflammation around the intestinal tract and lower your chance of cancer slightly. And lastly, I had to throw this in. It is true. studies do show that garlic will lower your risk of colon cancer as well. But take that with a grain of salt. I don't know if you want to take garlic pills every day. All right, so the main way to prevent colon cancer really is finding these polyps and removing them before they become cancer. And here we have the 45 or older, talk to your doctor about colon cancer screening, okay? Now, what do we find when we're screening? Well, it turns out that at age 50, which is what we were telling people to get screened at up until about 8 months ago, about 20 to 25% of people would have a precancerous polyp. So you got about a 1 in 4 chance of finding a polyp if you're age 50 getting your first colonoscopy, okay? That also means you have a 75% chance we're not going to find anything during your procedure. So, you know, if you get a colonoscopy and you don't find anything, you don't have to be disappointed, okay? You're just part of that 75% that didn't have anything. Now, these don't mean that you have cancer. This is just a small little polyp. They don't even have to be big polyps, but the data is 20 to 25%. And believe it or not, Medicare was actually keeping track of your polyp detection rate and using that as a quality control method of seeing whether you're doing your procedures well. So they were actually using this for data collection. Now the new age, going down to 45, that has dropped. So because it's a younger age, you're not going to find as many polyps. So now it's around 15 to 18% of people that we do a screening on at age 45 are going to have a polyp. So it's a slightly lower number, okay? All right, so there are a few different types of polyps. This one right up here is a hyperplastic polyp. It has little wispy lines on it. They're usually found in the distal colon, like the rectum, and they don't have any cancer potential generally. So they're not dangerous. They're not going to become cancer. But a lot of times, if we find anything like this, we remove it because we're not 100% sure all the time that it's a hyperplastic polyp. So if we find something like this, we do generally take it out anyway. I'm going to move on down to this one right here in the bottom right. This is a tubular adenomatous polyp. They have a sort of a more of a brain coral look to it. This is definitely a precancerous polyp. And then the third one I'm just going to mention is called a serrated adenoma, which is here on the left. These are a little trickier. They tend to be more flat. They tend to blend in more with the background of the colon, so they're a little harder to find. Like this one right here with the arrows pointed around it. Somebody put some methylene blue dye around it so it stands out better. But you could miss something like this a lot more easily. And they also tend to grow faster than the other tubular adenoma polyps. So they transition into cancer at a faster rate. So if somebody has serrated adenomas, I might ask them to actually come back a little sooner for a colonoscopy than if they had a tubular adenoma, okay? All right, so how do we find these polyps? Well, colonoscopy, as I mentioned before, that is the gold standard. That is the best method. It allows you to remove the polyp. It allows you to identify more polyps than any other method. But I do want to talk about some of the other methods that are out there so you're familiar with them as well, okay? So the first one I'm going to talk about is the FIT test. That's the fecal immunohistochemical test, which is basically a chemical test looking for minute, tiny amounts of blood in the stool, amounts that are so small you're not going to be able to necessarily see them with the naked eye, okay? Now, this is recommended annually, no matter whether you're going for your regular colonoscopies or not. So I think this is a good idea to do with your regular annual physical with your primary care doctor because it can pick up things that are going on in the GI tract. Now, remember, this is blood in the stool. It could be coming from your stomach as well. It doesn't have to be coming from your colon. I mean, anything that's bleeding in your stomach is going to work its way down and eventually come out the bottom there. So it's not specific to the colon, but there are some real benefits. This is very easy to do. It's cheap also. I mean, this chemical kit here costs about $15 to $17 to run it and to do the whole thing. The disadvantage, though, is that it's really not as sensitive as other methods. There's only about a 20% detection rate for a polyp that's 1 centimeter in size, and it's even less, you know, maybe even like 10% for anything smaller than a centimeter. So it's not going to pick up smaller polyps that are precancerous that have a little ways to go before they become cancer. It's going to be better at detecting bigger things that are in there. Maybe even colon cancer is probably about 75% or 80% effective at finding colon cancer that's already there. That would be a big lesion, okay? This also comes in a little card form called a guaiac test. It's not quite as accurate because the other test you run on like a special filter. This one is just color. So when you put a special dye on it, it's supposed to turn blue if there's blood in there. This is even cheaper. This is like a $5 test. Some of you may be familiar with it because you've gotten it from your physician before, and they say to put a little bit of stool on the cards and then mail it back in. But this is also a method for screening for blood in the stool, and then therefore potentially polyps that are bleeding a little bit on and off. Okay. Then that brings us to the combination test. So FIT, you can see, is right up here. That's the fecal-immunohistochemical testing. But then they add in some DNA testing to look for abnormal colon cancer type DNA. And this is, of course, Cologuard, which you've probably been bombarded with commercials for on TV. Now, you got to realize that there's some limitations here. First of all, it's not actually recommended as the primary means of screening, okay, for a number of reasons. I'm going to go over them in a second, okay? But it is recommended if people don't want to get a colonoscopy, then they say, well, okay, you can do this, but it's not necessarily recommended as the gold standard in this case. Okay, first off, it costs $500 or more for one of these tests. And you have to realize that it's also testing for blood in the stool. So you could do the $17 FIT test, and if it comes back positive, you don't have to send the $500 Cologuard test, because that's also going to come back positive because there's blood in the stool. The other thing is the company doesn't tell you if the test comes back positive, the Cologuard comes back positive. They don't tell you if it's positive because there was blood in the stool or if it was positive because it detected abnormal DNA. And I've actually called the company about this to say, well, can't you like tell me which of the two reasons that the test is positive? And they won't do it. But that would be useful for me as a practitioner, because if it's blood in the stool, then I need to know that I need to do an upper endoscopy as well as a colonoscopy to look for anything bleeding anywhere in the tract. So I have a little bit of a bone to pick, unfortunately, with the company because of some of the things that they've done with this. But let's talk about the test. Now, if you go to their website, just so you know, it says here in yellow, I've made it yellow, the test result should be interpreted with caution, and it says a negative test result does not confirm the absence of cancer. All right, so there's a reason that they put this in, so I'm going to talk about that now. All right, and that's because they mislead the public on this test a bit. Now, this is the New England Journal paper here, and I'm not going to read the paper, don't worry. This is from 2014, but this goes through on a table here what the real sensitivity or chance that it's going to detect what it's sent there for in these numbers. And I'm going to describe this as pictures in a moment, so it's a little easier. But if you look right here, this says colorectal cancer, any kind of cancer. The DNA test, which is Cologuard, has a 92% chance of detecting it. And that's actually pretty good. I have no problem with that at all. So if you have colon cancer, it's going to have a 92% chance of detecting it. The FIT test, the $15, $17 blood test for the stool, 73%. So it's definitely above that. 92 versus 73. But then you go down here to advanced precancerous lesions. That means a medium to large size polyp, but not cancer yet. Now we go down to a 42% detection rate with Cologuard and a 23% detection rate with the FIT test. So now all of a sudden you have less than a 50-50 chance of finding a polyp that's between 1 and 2 centimeters. Okay. And that's a significant size. I mean, 2 centimeters is a nice size, but now you only have a 42% chance of detecting it. And if it's less than a centimeter in size, the polyp, then you have a 17% chance of detecting it with the Cologuard test. So you have to keep that in mind if you're going for that test. So basically what that means visually is this. If you have cancer, which we have here in the picture, you have a 92% chance of detection with Cologuard. If you have a large polyp that's about 1.5 centimeters in size here, then you have a 42% chance of detection with Cologuard, which also means a 58% chance you're going to miss it. And then lastly, if you have a small, tiny little polyp, which is not cancer yet and probably is maybe 7 to 10 years away from becoming cancer, who knows, you have a 17% chance of detecting that. So I just want to make sure you're aware of that with Cologuard, okay? So it's a good test for finding very large polyps or cancer, but it is not effective at detecting small polyps. Now, a couple of other modalities. These are used occasionally. I have sent patients for these, but not commonly. One of them is CT colonography, which is a fancy CAT scan. And the way that works is the CAT scan computer generates a view of the inside of the colon here with special software, and you can actually fly through the colon the radiologist reads this, and if there's any polyps on the wall of the colon, now you've detected them using the CAT scan method. Now, there's some advantages to this. One is that you don't physically insert a scope, but that's not exactly true, because you do put a rectal tube in the rectum, and you inflate the colon with air for that test. So you are getting a little tube up just a little bit into the colon, and you are going to get cramping pain. There's no sedation used. You're going to get some cramping pain from the air being inflated. The disadvantages would include you still have to do a clean out to clean out your colon. So you still have to do that prep. The detection rate of polyps greater than a centimeter is actually very good. It's 94%. That's polyps greater than a centimeter. But if it's less than a centimeter, it's not accurate. So you have to keep that in mind. Okay. You do get radiation exposure. So if you're getting one of these CT scans every couple of years, that's going to add up the radiation exposure you get. Also, you cannot remove the polyp. So if you find something, then you're going to have to go prep again and go get a colonoscopy to take it out. And there's still a risk of perforation. Believe it or not, in the paper that described this originally in the New England Journal, also, there was 1 or 2 perforations out of a couple thousand people that they did CT colonoscopy on. And that's, I guess, due to the air insufflation. Maybe it was too much for the colon wall. Maybe they had some diverticuli pouches in the wall of the colon, and when they inflated it, it caused a perforation there. So there is still some risk to it in that regard. Okay. Last thing I'm going to talk about here, other than colonoscopy, which I'll get to in a second, is the pill cam. Now, we normally use these little pill cams, or they take little movies. They're not this big, by the way. They're much smaller. Okay. Wait, I even have a sample of one here. Let me see here. Where is it? Here it is. All right. This is the size of it right here. Let's see. Can you see it? Yeah, there it is. That's the size of these pill cams. Okay. Just so you see. All right. But anyway, the pill cam colon is meant to take a movie of your colon as it passes through, so that it can visualize if there's a tumor there or anything like that. Obviously, it's lowest risk of all of these things. I suppose there's a risk it could get stuck if there's a narrowing somewhere, but it's probably unlikely that that would ever happen. The only problem is the colon has to be distended, which means you have to drink a tremendous amount of fluids to distend the colon. And you may not see something, or if you see something, it's just for a second as it passes by, and you may not get a good look at it. And of course, you can't take it out with the pill cam colon, but at least it would let you know whether you need to be getting a real colonoscopy. Maybe somebody who's at a very high risk of being sedated and getting a colonoscopy, you could do something like this on. It is actually interesting. I've done some consultant work for the company. It's Medtronic, it owns it now. And they were talking about how in Europe, there's such a backlog of getting colonoscopies. People have to wait years to get a colonoscopy in some parts of Europe. And so they supplied all of these countries with these pill cams so they could screen people to see who needed a colonoscopy sooner than other people, so that they could reduce the backlog of people waiting for colonoscopies, so they could target those who had something that was found on the pill cam colon. So there may be some uses for that. So let's talk about the last thing here, and that's the gold standard. That is colonoscopy. Obviously, it is sticking a tube, a flexible tube. It's not latex, just so you know. And it goes all the way up across the colon down to the very beginning of the colon, because this is where the colon begins and the anus is where it ends, believe it or not. And this tube has a number of channels in it. It has an instrument channel that you can put things like forceps and snares and stuff like that through it. It has a camera lens. It has a light source. It has a water flush that flushes water through it. So there's a lot of things that you can do with the scope. It has controls on the top of it, which we control with our hand. Let's talk a little more. So first off, you're sleeping for this procedure. So you are perfectly comfortable for a colonoscopy, okay? You shouldn't feel a thing. We have an anesthesiologist that comes to our office that provides the anesthesia support for this. So my job is to do the procedure. It's the anesthesiologist's job to make you comfortable for the procedure. The anesthesia wears off very quickly. So when we're done with the procedure, within 5 to 10 minutes, you're waking up and you're able to get up and get dressed. You cannot drive home from a procedure because you're not able to legally drive after anesthesia for a number of hours. You're going to feel like you're totally fine, but they say, oh, maybe your reflexes would be a little slow, like you can't slam on the brake fast enough or something if you know a car pulled up in front of you or something. So they basically say, mostly for legal purposes, to wait a number of hours before you can drive. So you have to have somebody come and give you a ride there or pick you up after the procedure, okay? Also, you're supposed to be fasting the morning of the test because we're getting anesthesia, and you can't have anything in your stomach for that, all right? We used to do it without anesthesia. In fact, a number of countries still do colonoscopies without anesthesia, quite a number actually, and I can tell you that maybe half of the people that I've done without anesthesia were fine, but the other half definitely wish that they had anesthesia for the procedure, okay? And when I first started doing this, 20 something years ago, the GI doctors were giving a little bit of Demerol and Versed as anesthesia. We were not using anesthesiologists, and that was just terrible. I mean, this is much better the way we do it now, okay? All right, so here's some findings that you might see in the colon. This on the top left here is a normal colon, nice and clean. Here on the top right is a demonstration of a couple of diverticuli, which are those little pockets or pouches that occur in the wall of the colon. The colon is like a big tubular muscle, and these little pouches form where blood vessels feed into the wall of the muscle, where there's a weakness in the muscle wall where the blood vessels are, and sometimes they can pouch out and become these little pockets. This one down here on the left side shows the ileocecal valve, which is in kind of this yellowish area here, which is where the small bowel attaches. And then right behind the ileocecal valve is the cecum, and the appendix is back in here. And here's a picture of the appendix from the inside on this bottom right picture. Now, colonoscopy, when you're putting the scope in, you're going to see a view like this on the right. And here we have a polyp that's being seen, and this is going through the channel here. This is a little tube which has a snare in it, and we put the snare around the polyp, and then we burn it off. And we can either bring it through the channel of the scope if it's small enough, or if it's too big, we have to grab it with the snare and then pull the whole scope out and then put the scope back in. But we're able to treat the polyps as we see them while we're doing the procedure, okay? Cleanouts are very important here. On the left, you see a very nicely cleaned out colon, but on the right, you see somebody whose colon did not get cleaned out as well as we would really want it to be. And this is just going to hurt you if you're not cleaned out well, because we may miss stuff, you know, and I mean, there could be a small polyp sitting underneath this liquid. Now we try to suck it out as best we can, but sometimes it's too thick to suck out, or there are little chunks of stuff in there to keep blocking clogging the suction tubes in the scope. So it can be a problem, and it can reduce the chance that we'll find polyps and give you the best care possible. So please be careful when you do a colonoscopy to follow the prep instructions very clearly and do a good job with that. The clean out involves the following. The day before the procedure, you're probably going to be on a clear liquid diet for the whole day. Some people will say you can have a light breakfast really early on the day before. I generally dislike to tell people that, because people end up eating steak and eggs and pancakes and waffles at 11:30 in the morning and say, well, it was breakfast, and then they're not cleaned out. So, you know, so it's not one piece of toast and an egg at 7 in the morning. This is, you know, they have a giant meal because they think they're going to be fasting and it's late in the day. That's really a no-no. So I tell people it's just easier, be on the clear liquid diet for breakfast, lunch, and dinner the day before. You can still go to work the day before, no problem. Go ahead, be a teacher, go ahead, be a police officer, whatever, doctor, go to work, no problem. You're just going to be on clear liquids. And then when you get home later, like around 6 o'clock at night, that's when you're going to take the stuff that gives you the diarrhea. Okay. Now, one of the main ones that we like to give is this prep that involves Gatorade, which you have here on the right. There's going to be 3 bottles or 96 ounces, maybe 64 ounces, depends on your doctor, with 1 bottle of Miralax. And this bottle happens to say 4.1, but it's actually half of what we give. We usually give 8.3 ounces of Miralax mixed into the Gatorade, and you have a couple of hours, 3 or 4 hours to drink it all, and that's what's going to give you the diarrhea. Okay. There are some prescription preps that are out there. This is one called Suprep, which is sodium sulfate and potassium sulfate and mag sulfate mixed together. This prep is not acceptable if you've had kidney stones. So you shouldn't be using this if you have any kidney problems or kidney stones. Maybe if you have bad heart failure, I would not use this. But if you have good health otherwise, this is a great prep. It does a very good job. Instead of drinking the Gatorade with the Miralax mixed in, you're going to be drinking these 2 bottles. Sometimes we do split dosing, where you drink one the night before and the other one very early the morning of the test, along with a few glasses of water. It also comes in a pill form here called Sutabs. And so instead of taking the liquid bottle, you're just taking 12 tablets in each of these 2 bottles, along with multiple cups of water. And these prescription preps definitely do a better job than the Gatorade. The problem I have though is sometimes the insurance companies don't like to cover the prescription preps. But hopefully, if you go for a colonoscopy, your insurance will cover it. So the procedure itself takes about 15 to 20 minutes. We talked about anesthesia already. It's usually done here in New York, either in an office or maybe at a surgery center. If you have a lot of medical problems, we might do it at the hospital. If you have bad heart disease, bad lung disease, then we may not want to do it in the office. After you wake up, it'll be about 15, 20 minutes. You can get dressed. You cannot drive, as I mentioned before. And any polyps that were removed are sent to pathology to be evaluated. Could take a week or two to come back. If we don't find any polyps and you don't have any family history, then we're going to tell you to come back in 10 years. That is the official reading or the official guidelines right now. 10 years if there's no polyps. If you have 1 or 2 polyps, small ones, we might say to come back in 5 years. If you have a giant polyp or some other issue, we may even say to come back sooner. All right, so bon appetit. If you're looking for being screened, you're welcome to give us a call. My name is Dr. Tater. I also work with Dr. Silver and Dr. Korenfeld. We're located in West Nyack. This is what our office looks like from the outside. And this is our number. I'm going to hand everything over to Dr. Kronfall here, who's extremely capable and an excellent surgeon, one of the best I've ever met. And you can go ahead and talk, and then we'll take questions afterwards, okay?
Thanks, Dr. Tater. That was a great talk, and I appreciate the kind introduction. I'm going to start by just sharing my screen. All right, can you guys see that?
Yeah.
Perfect. All right, so just a quick introduction before we get started. My name is Dr. Kronfall. I am relatively new to Rockland County. I joined Highland Medical and Highland Surgical Associates about 9 months ago. I actually moved up here from Texas, which is where I did my general surgery training, and I did my colorectal subspecialization in Manhattan. And we eventually moved back here. We've been very happy with the move. We love Rockland County, and it's especially great working with excellent gastroenterologists such as Dr. Tater, Dr. Silver, and Dr. Korenfeld. The main part of Dr. Tater's talk, I think, is how important it is to get screened and prevent colon cancer. And if you do end up getting colon cancer, catching it at an early stage. Now, that's where I come in. If you are unfortunate enough to be diagnosed with colon cancer, or maybe you have a precancerous lesion that is very large and unable to be removed with the colonoscopy, that's where I come in. So the principle of management of colon cancer, any kind of colon cancer, is we need to remove the entire tumor with normal looking colon on either side, because we want to make sure we don't leave any little cancer cells behind, because those can propagate. So we can't just remove the tumor. We have to remove the part of the colon where the tumor is, plus some normal colon on either side. It's also very important to remove all the lymph nodes that are close to the colon once you go have surgery when you are diagnosed with colon cancer, because that will change the stage. If the cancer has spread to the lymph nodes or to other organs, the stage changes, and that can change the treatment you get. It doesn't necessarily change the surgery, but it may mean that you may need to get some chemotherapy or something after that. Of course, we try our best to not touch the tumor. We try our best to not even look at it if we don't have to, because we don't want to upset the tumor and have it spill some tumor cells and seed areas. We also, once we're inside the abdomen, we look around and make sure there's no signs of spread of the tumor. And all of this, plus some tests that the pathologists do, will kind of dictate what kind of treatment you get after the surgery. But I'm going to focus mainly on the surgical aspects of it. Usually stage 1 and stage 2 cancer will be treated just with surgery. Sometimes on high-risk tumors, especially on younger people, they'll get some chemotherapy for stage 2. Once the cancer has spread to the lymph nodes, it becomes stage 3. And those patients will generally have surgery, and then that's how we check the nodes. And then if any nodes are found to have cancer cells under the microscope, when the pathologist looks at it, then normally patients will get chemotherapy after. If, unfortunately, the cancer has spread to other organs like the liver or the lungs, usually the treatment is just chemotherapy. However, sometimes if it's an isolated spot on the liver that has some cancer, we can sometimes remove that as well. So some people with stage 4 will get surgery as well. But the point is, if you're diagnosed with cancer and you're seeing a surgeon, generally we try to do surgery to cure people. We don't do surgery to remove 99% of the cancer. It's important to remove all of the cancer. And if we don't think we can, then generally you just get chemotherapy. So before we get started on the details of the surgery, this is just what the colon looks like with its blood supply. And the blood supply is very important because this is where the lymph nodes are. They're close to where the blood vessels are. So this is the difference between doing surgery for cancer and removing a part of the colon for other reasons, like diverticulitis, for example. It's not as important to get the lymph nodes when you're not dealing with cancer. So when you are trying to remove all the lymph nodes by the cancer, it's important to take all of the blood vessels, which becomes an issue with what we can connect, because whenever you remove the colon, you're left with two ends. And our job after removing the cancer is to sew those two ends back together and make sure that that heals well. Because if there's a leak from that new connection, that can be a problem. Just like plumbing in your house, you don't want to have any leaks. And the most important thing to healing the new connection is good blood supply, because that's what has all the nutrients you need for the healing. That's what has all the oxygen and everything you need. So it's important to be well aware of where the blood vessels come. A, for the lymph nodes, B, for the healing after the surgery. So if the tumor is anywhere on the right side, from the cecum all the way up to this is called the transverse colon, this is called the ascending colon, any type of tumor here gets treated with what we call a right hemicolectomy. So where we remove about a third of your colon, the right side, and again, we make sure we get normal looking colon on either side of the tumor, and we remove all the lymph nodes. And then we sew the small bowel to the rest of the colon. Now the colon, you can live without the colon. We try to save as much colon as we can, but most people do just fine without a third of their colon or half of their colon. Some people even, you can remove all of their colon, and all that really happens is that they have to go to the bathroom a little bit more often and deal with some loose bowel movements, but generally you do fine. You can live without your colon. If it's on the left side, this is called a left hemicolectomy. Again, similar to the right side, but except we're removing the left side of the colon and we're reconnecting this part of the colon down to the lower part of the colon. This part of the colon here is called the sigmoid colon, and we can remove only the sigmoid colon and reconnect the descending colon or the left colon down to the rectum. And I'll get to how we do this in a minute here. Now, once the colon is a little bit lower down, things change a little bit. It becomes a little bit more tricky for us. And we have to remove the rectum and we reconnect the left side of the colon down to the very bottom of the colon or even the anus. A lot of people, when they come see a surgeon, the first thing they'll ask about is the bag. Do I need a bag? Generally, to be honest with you, the answer is no. And what a bag is it's essentially a colostomy or an ileostomy where we take the intestine and we suture it to the skin. And instead of having bowel movements through the rectum and anus as you normally would, the stool comes out of the colostomy and gets collected in a bag. And understandably, people don't really love having this. And in general, we don't have to. But I will say, once we get closer to the anus, closer to the end of the colon, this is when it becomes a little bit more difficult for that new connection to heal, like I was just talking about. So when it's very low, and especially if you've had some radiation maybe, that's when we would protect this new connection with an ileostomy, and it would be temporary. The only time you would get a permanent colostomy is if the tumor is so low that it's invading the sphincters. The sphincters are the muscles down in the anus that hold everything in and prevents incontinence. Those are very important muscles. If the tumor is that low, we have to remove those muscles as well. And sometimes we remove the anus in addition. Now, once you don't have those muscles and don't have an anus, we could technically, connect the colon down, but then you have no control. And essentially, it's much better to have a colostomy than basically just have uncontrollable bowel movements. So this is very rare these days. between the advances in surgical techniques and chemotherapy and radiation, usually we can shrink the tumor enough to get it off of the sphincters to avoid the permanent colostomy. And then you would get a temporary colostomy. And when I say temporary, usually that means about 6 weeks. So it's not ideal, but it's a lot better than having cancer or having a leak from the new connection. If there's multiple tumors in different areas, or there's a high risk of having cancer, like a BRCA gene or the FAP gene, like Dr. Taylor was talking about, we will remove the entire colon and we can reconnect the small bowel to the rectum. Sometimes we have to remove the rectum as well. In patients with FAP, the rectum is at risk as well. So sometimes we'll remove the rectum and the entire colon, but we leave the anus and those sphincters. In these cases, we can actually fashion what's left of the small bowel into basically a new rectum by making a small bowel pouch and connecting this to the sphincters. Now, all of this used to be done with big incisions from the breastbone all the way down to the pubic bone. And that's still fine. And a lot of people still do that. And there's nothing wrong with that, because the most important thing is to remove the cancer and to put people back together without having to live with a permanent colostomy. But these days, we are able to do it with smaller incisions, what's called laparoscopy or robot-assisted laparoscopy. So basically, we use a camera and long instruments without opening up the entire abdomen, and we're able to remove the colon, the part of the colon that we need to remove that way. And many studies have shown that oncologically, this is the same as doing a big open operation, but there's a lot less pain. People stay in the hospital a lot less time. They're quicker to go back to their activities. They go back to work, go back to whatever they want to do much quicker. So it's much better, if possible, to do it with the smaller incisions, which again goes back to the fact about catching these things early, because if it gets to the point where it's perforated or it's causing a blockage, it can be very hard to do it with the small incisions that way. And this is what laparoscopic surgery looks like. We basically access the abdomen with these little ports. Instead of a big incision, we put 3 or 4 smaller incisions and we put trocars or ports through this, and we can put a camera through one and all the instruments we need through the other ports. And this is what it looks like. The surgeon stands here controlling these two, and he has to have some help depending on, because we only have 2 hands, depending on how many ports are in use. Someone has to hold the camera, and usually there's an assistant who has 1 or 2 ports and helps with retraction and moving things out of the way for the surgeon to remove that part of the colon. And this is what it looks like on the inside. Dr. Taylor had some great pictures about the inside of the colon. Well, this is what the outside of the colon looks like in the abdomen. And this is the sigmoid colon. This is going down towards the pelvis. The rectum is here. And you can see this is an instrument that we use to cauterize blood vessels and cut things. And we're able to remove the colon that way. And you can see it. One of the limitations is that it's a straight stick when you're doing laparoscopy, unlike real life where you can move your wrist. And I'll get to why that's important in a second here. So after laparoscopic surgery in 2002, robotic surgery came into play. And what the robot does, it's called the Da Vinci Xi robot, and we have one at Nyack Hospital. It's 3 integrated elements. It consists of a surgeon console, a patient side cart, and a 3D vision system. And these, it's very similar to laparoscopy, but there's different instruments. And instead of you standing by the bedside, the surgeon sits down here and is able to see things 3-dimensionally by putting their head in this vision area and using these little joysticks to control the arms of the robot. So it's not like the robot is doing the surgery. The surgeon is still manipulating and moving the arms of the robot, but we're sitting down and the robot, the ports, the instruments are connected to the robot, and we control the robotic arms. And this is what it looks like on the inside. One big difference between this and the first picture I showed is you can see how these instruments articulate. So you have wristed motion, which you don't have when you're just operating with straight sticks, which makes a huge difference. Now, once we remove the colon, this is a good example of, this is the small intestine, and this is the colon. This is how we put it back together. We usually sew it back together, or we can use a stapler to connect the 2 ends of the colon or the small bowel to the colon. And this is what it looks like in an actual OR with the robot arms docked and the ports in place, and the surgeon sitting down and manipulating these instruments. There's some disadvantages of laparoscopic surgery. Normally it's the cost and the operative times, which really, as you do more of these, the times decrease. But that was a big issue in the beginning of robotic surgeries. It would take so much longer than open or laparoscopic surgery because everyone was learning a new system. But now we're at the point where it doesn't take any longer. But sometimes it helps to put your hand in there so you can feel things, which you can't do with the robot. The advantages over laparoscopic surgery is that the instruments articulate. It's a 3D image instead of a 2D image. It's nice that we get to sit down, I'll be honest with you, so my back doesn't hurt after the surgery, because these are long surgeries, and it sounds like we're being spoiled, but you know, I'd like my surgeon to be comfortable if he's sitting there doing a 4 or 5 hour case, rather than getting to the end and your shoulder hurts and your back hurts. You have more control of the case, because you're actually, when you sit down, you're actually controlling 4 arms. Because you can control all the robotic arms at the same time. As opposed to laparoscopic surgery, you only have 2 hands, so you can only control 2 arms. With the robot, you actually have a lot more control of the case. And there's technological advantages to the robot as well, like the ability to check perfusion status. One of the things I said that's very important in this new connection healing is the blood supply. Well, using infrared technology, we can actually inject IVs, a green dye, and it will pick up where it is well perfused or has good blood supply. So we know that our new connection is going to have good blood supply by checking it under the infrared light. So you can see here, it's black, it's dark, not green. That doesn't have good blood supply. And with a click of a button, we can see where is there good blood supply, where is there not good blood supply, which will increase our chances of healing that new connection well and decrease the chance of any complications. So that's the gist of what we do when we have surgery. Real quick, I just want to touch on something that's even newer. This was developed in 2009. It's called transanal minimally invasive surgery. This is not something we do often, but can be very beneficial in very specific situations, such as large polyps that are not able to be removed with standard colonoscopy, or very, very, very early cancers where we're not really worried about the lymph nodes. So what this is we actually put a port that looks like this. We actually place this through the anus into the rectum, and sort of like a colonoscopy, blow up the colon with air, and we can remove the entire polyp or cancer without having to go into the abdomen at all. So a lot of times, I mean, they're precancerous, but they still need to be removed. And back in the day, before 2009, we used to still have to do a full surgery with a colectomy and possibly a bag for these rectal lesions, because they were too big or too difficult to be removed with the colonoscopy. But nowadays we have this, and I'll show you what it looks like in this quick video. So this, just to orient everyone, we're now about to go put a camera inside the rectum. And here you can see the tumor that we're removing. It's pretty small, but it's still if we don't remove it, it's going to turn into cancer. It's going to cause a big problem. So that's what the rectum looks like. And then we use these instruments, which is the same thing we use for regular laparoscopic surgery. This video, by the way, is sped up a little bit, so I don't operate that fast. But then we can actually, without having to make any incisions into the abdomen, we're able to remove the entire tumor. This is now regular, not slow motion. This is what it actually looks like. And then when we're done with this, we just close that hole that we made in the colon using sutures. It's a very small area, so it's tough to, sometimes there's a lot of banging. But this patient, for example, would have ended up having a very large 6-hour surgery with an ileostomy. Instead, we're able to remove it that way. And once the tumor is out, we just close up the defect. There you can see with some stitches. So this is helpful. It's a very small indication, but can really save people a big surgery and a big recovery. And then we just suture it closed like that. And they usually go home the same day or the next day, instead of, several days in the hospital and recovering from surgery. it doesn't hurt at all because we're inside. It's like the colonoscopy. There's no nerves on the inside, so there's no pain associated. And when we're done and the cancer is cured, we usually make ourselves a sandwich with the robot because the robot can do anything, but we have to control it. Thanks.
Thank you so much, Dr. Kronfeld. The sandwich is a good idea, especially now that it's lunchtime.
Yeah, we
But
get
I don't
hungry
know if
after
I
a
will
long
be
case, I
eating
gotta
it.
tell you.
After I saw what the robot can do, I don't know if I'll be eating a sandwich out of that hand. But anyway,
Well, we
thank
clean
you
it
so much.
first.
Thank you so much to both of you. We have a lot of questions, and I know that we are going a little over 1 o'clock, but this is all great information. So I'm asking our attendees to hang in there. And if you have to really go, don't worry, because you know that you're going to be getting the link to the recording. So if you have any questions, just write them there. We're going to get to the answers, and I'm going to send you the link later where you're going to find the answers. So let's start here. Is there immunotherapy for colon cancer?
You want to take that, Dr. Tater?
Well, I don't know about, I mean, there's immunotherapy is a fairly new group of medications that are out there. I know that they're very effective for certain things. For melanoma, for instance, is very effective. It's very effective for that. I know that there was a new monoclonal antibody that was supposed to cure rectal cancers. That a paper came out, or some kind of a news information came out about maybe about 6 months ago. But I don't know the details on that. I'm not an oncologist, so I don't know, the details on that stuff.
Yeah, I was going to say the same thing. That's a good question for the oncologist. But yeah, I think it depends on the type of tumor. So they test it under the microscope. They do some tests on the tumor and a certain subtype of cancer, because not all cancer behaves the same. Not all cancer reacts to chemotherapy the same way. But there is a subset of patients that it really does show that the immunotherapy is beneficial in specific types of rectal cancer.
Okay, we will find an oncologist to come and talk to us about immunotherapy. So great question. If you have a colonoscopy every 5 years, with or without polyps, what are the chances of getting cancer?
Well, all right, a colonoscopy is not perfect. They've done studies where they looked at people that got a colonoscopy and they identified where all the polyps were, but they didn't remove them. And then they sent them to another gastroenterologist. And I think maybe they even went to 3 different GI doctors in this study. And they wanted to see whether every single GI doctor found every single polyp. So it turns out that if you have a polyp in your colon, a colonoscopy is not 100% accurate at finding that polyp. It's maybe 95%, 96% accurate at finding the polyp if it's there, but you will miss polyps. So you could miss a polyp around the backside of a fold. Maybe the prep isn't perfect, so there's a little bit of like liquid floating in there and you just miss it. Or maybe there's contractions in the colon and it makes it a little harder to see. So it's not perfect at finding every single polyp. So my own thought is with this 10-year return thing is that if you're one of those 3 to 5% of people who had a polyp but it wasn't found during the colonoscopy, now you're setting yourself up for a problem in 10 years from now, because it is probably most likely a really tiny little polyp, but now you're waiting another 10 years. So if it were me that were making the guidelines, I would have probably said, do a colonoscopy at whatever age 45, then do another one 5 years later. And then if you didn't find anything on both colonoscopies, then you could go to every 10 years. That would have been my preference, but I'm not the one that makes these guidelines. There's a lot of factors that go into it. Nothing is ever going to be perfect in any of these screening tests. Something will always fall through. I mean, that goes for prostate cancer, for breast cancer. So they're not 100%. You can't guarantee anything, but it is the best that we have, and it does do a good job. If you're getting a colonoscopy every 5 years and you didn't have a family history and you didn't ever have a polyp, then you're not really abiding by the guidelines per se. There are, some GI practices where they ask people to come back very frequently. It may be outside of what the guidelines are. Sometimes the insurance companies crack down on this and say, no, you can't get a colonoscopy. It hasn't been 10 years yet. And so sometimes that depends a little on your insurance company. Medicare will be very strict about the 10-year thing, whereas I believe Aetna and Fidelis will allow for you to get a colonoscopy every 5 years and pay for it. So it may also depend on your insurance company and other things too. I mean, if you're having symptoms, you may need a colonoscopy rather than just pure screening.
If you were gonna have to pay for a colonoscopy out of pocket, because let's say I wanna have it every 5 years and my insurance doesn't wanna cover, how much is it to have the colonoscopy?
Well, I mean, look, as I said, the insurance usually will cover it if you happen to have some kind of a symptom, you know, if you happen to see a little bit of blood in the stool or something like that. So, I mean, I would, you know, I think you need to talk to your doctor about whether you do have any kind of symptoms that might have popped up that would warrant it. But if that is not the case, then, you know, I mean, look, every place is going to be different in whatever they charge for something like that. But I would assume that if you're paying for anesthesia and the procedure, it could be anywhere from, you know, $700 to $1,200, somewhere in that range for everything. You know, it just depends where you are, where you're getting it, what the people charge for it in their office, that kind of thing. What anesthesia is charging. I mean, I can't put a price tag on it. You know, that's something that depends on the practice and what they have. We have in our office like a sheet of paper that says if you don't have insurance, this is what we charge. So it's a set amount that we have on there. So it's not even like you negotiate or dispute it. And it's up at the front desk if anyone calls or comes in without insurance and needs to get something, it's all written out there.
Thank you. Does having diverticulitis make you more susceptible to getting colon cancer?
No, not that I'm aware of. No, I mean, but the problem is that diverticulitis colon cancer could mimic diverticulitis. So if you haven't had a colonoscopy in a few years, then you probably need one just to make sure that there's not a tumor there that's looking like diverticulitis, but it doesn't increase your chance of getting colon cancer.
Another question is, it seems that the cleanse is the worst part of a colonoscopy. Are there any new methods being developed to make this process more reasonable? And I know that you explained a lot of them, so.
Yeah, no, unfortunately, there's no easy way out. You're still going to have to be on the clear liquid diet, and you're still going to have to choose one of those types of preps that I talked about before. You know, if you're doing a flexible sigmoidoscopy and you're only looking at the very bottom few inches of the colon, maybe the bottom third of the colon, you may be able to just do some enemas instead of doing a whole colon clean out, but that's not the full colonoscopy. But unfortunately, there's no easy way around this at this time.
Do the home screening tests recognize the difference between colon cancer and bleeding from hemorrhoids?
Well, the FIT test and the Cologuard test both will be positive if there's blood in the stool. So they don't differentiate the cause of the bleeding. They just say that there's blood there. You can sometimes get a better sense of things, you know, if it's fresh blood, if it's just on the toilet paper, if it is not mixed into the stool and just apart from the stool. You know, that would all be things that lead you to believe that it's probably from hemorrhoids, but you don't want to assume anything. Sometimes in these cases, it would be very easy to assume somebody has bleeding from hemorrhoids, and then occasionally you're going to be wrong. So it's, you know, you don't want to get caught in that situation. And even though maybe 98% of the time it is hemorrhoids, that one time that you're wrong, it could have catastrophic effects.
And I'm going to read these two questions together because they kind of relate to each other. Is there an age at which the risk of a colonoscopy outweighs the benefits? I have a friend, this is the other one. I have a friend 80 years of age, and the doctor said no more colonoscopy. At what age do they stop the test?
Okay, I don't want to be taking all the answers, but I'll just answer this one unless you want to. Do you want to do it, Zion?
No, I mean, I think, correct me if I'm wrong, but I think the guidelines are saying you stop at 75. But I got something to say about this because not every 75-year-old is the same, right? Like it's a chronological age, but the physiologic age, some 75-year-olds are, you know, running marathons and some 60-year-olds can't get out of bed. So I think the purpose of stopping at 75 is that if your last colonoscopy at 75 is clean, you'll probably die of something else before colon cancer if you have no polyps. But that depends on the patient, right? So I don't know what you think, Dr. Tater. How about that?
Yeah, if they're over 75 and they're not in that great of shape, then I would say you don't need anything else. But I will do colonoscopies even in the office up until 80 or even 81 or 82 if you're in good shape.
Yeah.
I mean, so I think 80 is 75 to 80 is the cutoff, depending on your health. I think 75 is the official cutoff. But we do it up to age 80, maybe even 81 or 82 if you're in really, really good shape. But I think after that, you can't really justify it because there's a risk of the anesthesia, there's a risk of the procedure. So generally 80 is pretty much the hard line, except for a few exceptions where people are really, they're 80, but they look like they're 60, that kind of thing.
Yeah.
And I like this question a lot. What contributes to patients dying from colon cancer if there are so many options to find it and treat it?
I'll let you go.
Well, I think the issue is when it's contained, there's a lot of options between surgery. If it's spread, that's when the issues come about. So if it's in your liver and your lungs, and not every cancer responds to chemotherapy the same way. Some of them will melt away with the chemotherapy, and some will grow and continue to spread despite maximum chemotherapy. So that's really what contributes to it, is that as the tumor spreads and becomes more numerous, your body becomes weaker and sicker. And it's not necessarily that people will die of the cancer. It'll be that the cancer is spread and has caused other problems in addition to just the cancer.
The other thing is, if you look at the statistics from earlier, it was only a third of the people. There was 150,000 people are diagnosed a year and 50,000 die. So it's only a third of the people that get diagnosed die of it. So 2/3 are surviving the colon cancer.
And again, that depends on the stage. So if it's stage 1, it's over 95%, I think, cure rate when in the early stages. So it's more the spread and the continuing.
And one more. Are hemorrhoids a precursor for colon cancer?
No.
Nothing to do with it. Yeah.
Oh,
So just so everyone knows, you're born with hemorrhoids. 2 arms, 2 legs, 3 hemorrhoids. Everyone has hemorrhoids.
that's a good one. Okay.
They don't cause problems with everyone, but everyone has them.
Oh, that's good to know.
But that's a whole other talk we can get to later.
That's another one, Dr. Crumfold. You're coming back for that one, okay?
Sure.
Dr.
Okay.
Kronfeld is a very, very experienced with hemorrhoid stuff. That's one of his main specialties.
Yeah, so we'll do one on that because I know that a lot of people have hemorrhoids, as you say, and they are problematic.
Yeah.
Well, thank you so much for answering all the questions. Let me make sure that I answered them all. Yes, I did. Okay, so thank you so much for being here, Dr. Crumfold, Dr. Tatar. It's amazing to have you. We learned so much about this, and all the pictures were great. I'm not a surgeon and I don't like blood that much. And so that's why I'm saying they were great, because they really gave us the picture. So thank you so much for your presentations, for your talk, for answering our questions. And to all of our attendees, I will be sending you the recording later today. And next week, we're going to be talking about this one here, autism and the seeds of change, nurturing the brain of a genius. So that's going to be a very interesting topic. So I will see you here next week, 12 o'clock, at Community Chats. Thank you.
Thanks. Bye-bye.
Bye-bye.
Bye.